thank you everyone for signing up and for coming to this education seminar tonight, which is one we really hope will be very helpful in understanding how the virtual services, virtual ED, the virtual specialist consults can work for you, for the patients, for the whole of Victoria, and how it's really improving access to patient care and patient care in general. And we have two very distinguished presenters with us tonight, who I'll introduce as we get to each section. First will be around virtual ED and then around virtual specialist consults. Next slide, please. Well, thank you. I'm Morgan. I'm a GP, and so my job is around seeing how we can best make mainly virtual specialist consults, but also, I suppose, in this context, if you have any thing we can feedback around virtual ED as well. Very keen to get contacted directly or through the Facebook groups and any other means to see how we can improve any aspect of the service for you and your patients. Next slide, please. And from wherever you're joining on, I can talk for where we are, which is under Northern Health, and we acknowledge the traditional custodians of the land on which our health service is built. Those are the Taungurung and Wurundjeri people, and we acknowledge their continuing connection to land, waters and community, and pay our respects to the people, the cultures and the elders, past and present, and to anywhere you're joining from today. Next slide, please. So for the majority of the presentations, it's just all listen only. There might be points where it opens up to questions. Otherwise, you can put them in the chat and I'll collate them for the end. If you would like a CPD certificate for this event, there will be a survey that we put up at the end, but also we can always follow it up. And I log everyone who is joined with the college, so you should get it either way. And this webinar is being recorded, so if it'd be helpful to share with colleagues of yours or with your practice, please let us know. And next slide, and I think that's an introduction slide. So we're very lucky to have Dr. Lauren Sher joining us, and an emergency specialist and the program director of the virtual emergency department, and really leading the way, especially in Victoria, around digital innovation and healthcare, but also across Australia. So Lauren pioneered Australia's first virtual emergency department model, which is now the statewide service. Former director of paediatric emergency at Northern Hospital in Epping, Victoria, and is very passionate around the equitable, kind of high quality care, specifically to everyone, but targeting parts of the population which are traditionally unable to access care very well, those vulnerable communities, and is completing a PhD in digital healthcare at La Trobe. So yeah, Dr. Sher's really redefining how emergency care is combining and blending the compassion, the innovation, and the impact across the state and outside of the state now. So I'm very honoured to hand over to Lauren. Thank you for your time.
Thanks, Morgan, for that very generous introduction, and hello to everyone online. So today I'm going to take you through a talk called Virtual ED and Beyond. What I'm hoping to do is give you a brief introduction into how Virtual Emergency Department came to be, take you through some of the expansion, and then maybe discuss a little bit with you about how you and your practice could be working with us and how we can work more closely with you moving forward. So, for many of you who do or don't know, Virtual ED was born during COVID. It was an idea that came out of an innovation session with our executive, looking at interesting or different ways that we could provide healthcare to our local community outside the walls of the hospital around Northern. Essentially, we were trying to solve two problems. One of them was that patients were quite terrified to come to our hospital and were presenting quite late to the emergency department with quite advanced disease, and we were seeing advanced ischemic events, gangrenous gallbladders and appendices because nobody wanted to come in. But as a hospital, we also had the challenge of wondering how to actually achieve things like social distancing in a hospital. Most of you may or may not have seen the Northern, which is one of the busiest EDs in the state has very small real estate for the amount of patients that we see. And so this was a real challenge for us about how do we protect our patients and how do we protect our staff. And so this idea of could we provide some urgent virtual care to our patients was born. And in October 2020, we launched the first iteration of our model. The first model was teeny tiny. We had only 3 people on every shift between 1 and 9 p.m., which is our peak presentation times at Northern ED. And we had 1 nurse, 1 administrator, and 1 emergency physician. And when we launched two significant referral pathways, and those referral pathways are essentially the same now. They've just expanded. So some people might have heard us referring to our self-referral pathway or direct-to-consumer pathway. And these are patients in our community who could self-elect to use our service. They would click onto a registration form that was available via QR code or online, fill in all the details they would ordinarily fill in. If they'd come to the emergency department, and on submission would enter an ED wait queue in a nurse virtual wait room. Our emergency nurse would then click on them in the wait room, take them through a virtual video triage, and based on their assessment, divide them into 4 categories. Category 1 would be considered too unwell or very unwell for our service and needed urgent transport to a hospital, either via ambulance or self-transport. 2 or 3 could come through to our virtual wait room to be seen by one of our doctors, obviously 2 being a high category, then 3, and 4 was too well for our service. So we recognized that there would be a group of patients that contacted us and really just needed self-care advice and direction back into primary healthcare or community care like pharmacy, for example. For those patients that did come through to us in the emergency wait room, they would then be seen, and we would organise all sorts of dispositions, which I'll take you through in a moment. Feeding concurrently into our emergency physicians wait room were what we call our healthcare provider pathway. So in the first iteration of this model, was with aged care facilities in our local area, some of the urgent care centres that feed into Northern Hospital, things like COVID positive pathways. It seems like such a long time since I've said that. So any sort of provider in our local community could do a co-consult with us. They too would come through using a different registration form that would bypass the nurse. And the assumption would be that they didn't need to go through a nurse triage because they, as a healthcare provider, had already identified the patient as being appropriate for our service. And so they would come straight through to the emergency physician's consult room and we would do a consultation. Now, as we evolved the model, we created all sorts of interesting dispositions and pathways back into community and into the hospital. So we could direct refer into outpatients, we could go direct into HIT, for example, direct to short stay, direct to back to primary healthcare, whatever we thought was most appropriate for the patient. Essentially, the idea was we would try and keep patients out of the emergency department that did not need to be there. I always say emergency, to get to a specialist outpatient appointment, you don't need some special stamp in some special passport. You can just be directly directed to where you need to be. Now, if you look at the model as it exists today, what has changed? We've now become a 24/7 service based on our expansion. So that expansion started and ran concurrently with COVID coming to our shores. First, we started by expanding out with Ambulance Victoria across Metro, and then we went statewide. And eventually we expanded all our models as we became the statewide provider of virtual ED care, expanding that to aged care facilities, urgent cares, for example. So this is some of the partnerships that helped us in that expansion. So you can see that we have started off with COVID positive pathways. We started by bringing in the aged care facilities, Ambulance Victoria, urgent care centres across regional Victoria. We then did some work with Ambulance Victoria looking at aged care facilities, again, further expanding aged care. And along that journey, we've brought on nurse on call, maternal child health nurse. So this is how we've expanded the virtual ED. And using these pathways, there we go. You can see that we've managed to expand well across the state of Victoria. There is no area within or region within Victoria that isn't utilising us. We still do tend to have a little bit of a hotspot around metro, particularly around the northern suburbs in our self-registration arm. But actually, if you look at our healthcare provider arm, we're well distributed across the state. Now, we often talk about this magic number of 80% diversion. And, you know, for most people, that's the big thing. Virtual ED is about keeping patients out of ED. And we say we keep 80% of our patients that we assess out of ED, which is an amazing achievement for us. And we also talk about the impacts that this has had on the state. And so some of the things that we've seen is that since we've brought in things like the virtual ED, we know that category 4s and 5s across the state have decreased in terms of presenting to ED. So we're having a significant impact on low acuity presentations to emergency departments. People often say, but the numbers are still increasing. Yes, the numbers are increasing because the acuity is increasing. So unfortunately, 1s, 2s, and 3s are increasing. And really, we understand our scope and our place, and we can't prevent or interfere with patients who need that level of care going to an emergency department. But some of the really amazing things that we have achieved, and this was done through a quite extensive health economic analysis, is if you look at some of our data from one financial year to another, despite almost doubling in size and number, you can see that our efficiencies have been consistent. We've managed to avoid thousands and thousands of ambulance ramping events. So that's thousands and thousands more paramedics available to attend category 1 and 2 patients across the state. On any given day, we're saving 32 equivalent cubicles or more currently, and the hospital beds as well. Our current numbers, so, in 2023 to 2024, we saw 195,000 patients. We're well on track to see over 400,000 this year. In fact, we're about to hit 1 million patients since inception. So our growth has been exponential and quite significant. We currently see about 1,000 patients a day. On the weekends, we peak at 1,200 to 1,300, and we usually see an uplift of about 30% over the peak holiday periods as well. But we always talk about, while we always focus on the diversion of and what we've achieved in virtual ED, I wanted to bring it back home and give us an example of some of the other kind of work that we do. Is something that's probably not well identified in our service, and something we don't talk a lot about. So I thought I'd talk about a patient that I've seen in my practice. So this was not too long ago. This was a patient, we'll call her MJ, and she was an 18-month-old female who presented to virtual ED one evening. She'd had no relevant birth or medical history to note, and really just presented with a history of 48 hours of fever and mild coryza symptoms. She had seen her GP earlier that day because she had developed a rash, which looked very much like a blanching maculopapular rash, looked very viral. She had been discharged with a diagnosis of viral illness, and her GP had actually safety netted the family with, if she gets worse, please contact VED. So they did. They contacted us 6 hours later, post the GP, to say she'd become increasingly lethargic. She had started vomiting, and over the last 2 or 3 hours, the vomiting had been quite profuse, and generally the parents were quite concerned. During the consultation, and I'll just say, complete acknowledgement, I've pulled this randomly off the internet, but I just wanted to show it for depiction. During the consultation, MJ was actually lying on her dad's chest. And it was very interesting because while he was talking to me and giving me this history, he suddenly lifted his hand. And what I noted was that while we were just talking, there was a handprint that stayed on that child's body for 7 seconds. And I remember thinking, oh my gosh, I think this child has a significant delayed capillary refills. And at that point, I stopped the consultation and I jumped to the assessment and asked the parents to check the central cap refill. And she was indeed a very lethargic, miserable child, but more concerning, her central cap refill was 7 seconds. At this point, we paused the consultation and we decided that she needed emergent transfer, lights and sirens, to hospital. And this is where I think virtual ED really does have some magic special sauce with some of the specialists that we have available in our service. So I managed to call AV and ask them to license sirens and ambulance to us and get the parents ready for transfer get their nappy bag ready and all that jazz while ambulance were arriving. When ambulance were on scene, I asked them to please attend, and I directed them, and I won't say which one, to a specific emergency department that I knew would have the capabilities to manage this patient's acuity and direct access to a PICU. Once they had loaded the child, I then notified the emergency department they were transporting to let them know they had a really unwell child en route that I thought was in septic shock and they would be receiving in the next 10 to 15 minutes. I was fortunate to follow this child's journey, and the parents were really amenable to providing me with regular updates. And within 2 or 3 hours, she was intubated and in PICU on quite high doses of inotropic support. Now, I was very lucky, as I said, to have developed this relationship with the parents that they would give me updates. And I know that she spent almost 2 weeks in hospital. So she did survive, which was fantastic, and then and made it home. And little MJ had a really good outcome. She did have some complications, so she developed a contracture from a sort of a Falkman's contracture type situation in her one leg, which required a tendon release. But her parents were very, very grateful for the care and the referral that they had received. And her parents actually participated in a television series that was running about sepsis, more specifically because she had actually grown group A strep. The news piece was about group A strep. And interestingly, they were talking about how they just were so uncertain about whether they needed to go into hospital or not in that moment because they'd just seen a doctor. But we know as clinicians that children can just deteriorate so quickly and change. And so it was really rewarding for us to see how having that safety net and that ability to provide out of hours specialist care to her managed to help get her the quite urgent care she needed. So I think what I'd really like to emphasize in this is, yes, virtual ED is about diversion, and yes, we're about keeping patients out of the emergency department that are of low acuity, but we're also a safety net for your patients when your practices aren't open. And you're also a safety net for us because we see a heap of patients that come through the virtual ED that need results checking, that need clinical in-person review, either in the next few days or on the day. And we know that virtual has its place, and there's just some things that cannot be replaced by video health. And so really, I'm hoping as part of this talk to just encourage and reach out to you as a GP community to just say, if there's anything we can be doing better, please let us know. We're always trying to iterate and improve our processes. And similarly, if things have gone well and you want to give us a shout out, let us know as well. We really want to see this as we really do see this as bridging the gap between pre-hospital and hospital, and just changing the landscape of virtual care in Victoria and the way that we view it. All right, over to you, Joe. Do you want to,
Thanks,
do you want me to
Lauren.
stop sharing?
Yeah, we're just going to swap presentations. So we're just going to swap over to Associate Professor Lawrence. Lovely, thank you.
Oh, not from the beginning, sorry. We'll just whip through Lauren's presentation on speed. Had it all set up. There we go.
Thank you. Thanks, everyone. So then this part of the talk focusing more on virtual specialist consults, and then make sure we've definitely got time at the end to cover questions to both arms of the service. And any specific questions around maybe Medicare, billings and such, I'm happy to help cover as well. So Associate Professor Lawrence she's a paediatrician and a health systems leader, and has been focusing on improving access to the high value and sustainable healthcare models, and has done a doctorate through UNSW, examining the ways to reduce that wasteful care in paediatrics and avoidable hospital admissions. She holds leadership roles with the Virtual Emergency Department and is a director of the Virtual Specialist Consult Service, alongside a long-standing role with the Royal Children's Hospital in Hospital and Home. And her work is really focused around that redesigning of healthcare to deliver safe, high-quality care, keeping patients at home, reducing unnecessary transfers, and is very passionate with working across all health services and especially with primary care. So pleasure to introduce Associate Professor Lawrence.
Thanks, Morgan, and welcome everyone. Thank you for joining us tonight. I recognise that the majority of you have joined us through a VSC flyer and therefore are aware of virtual specialist consults. So I am somewhat preaching to the choir, but it's a really nice opportunity to share a bit of the background about what drives us, what's motivated us to stand up the service and what we hope we're achieving, as well as how you can get the best out of a partnership with us, and hopefully leave you with a really strong sense of why it's worthwhile using us and what you can get out of that relationship. And then obviously we'd love to hear your feedback as well. If you have, many of you will have used our service and I'm sure have suggestions for how we can further improve. So I'd like to start with sharing a story of Jordan. Jordan is a 28-year-old basketball player. He's got long-standing asthma, which has been well managed by his GP. But in the last few months, it's become increasingly difficult. He's unable to participate fully in his basketball games and often has to sit on the bench for the last half. And his GP has really reached the limits of her experience and expertise and feels like he needs a referral to a respiratory consultant. So she makes the referral. Anyone working in Victoria will know what our current specialist outpatient clinic system looks like. For Jordan, this looks like an 18-month wait on the waiting list. During that time, he goes through 5 reliever medications. The more blue puffer or Ventolin you use, the more likely you are to have a severe asthma exacerbation, end up in ICU, and even have a higher risk of death. He's unable to fully participate in basketball. His ability to participate gets less and less, and ultimately he ends up quitting. He starts putting on weight. It has an impact on his mental health. He also works casually at Woolworths, moving boxes, and he's unable to go to work in a cumulative period of about 2 weeks over this period of time. As he's self-employed, he starts to worry about his finances and wonders whether or not he'll be able to pay his rent. And then he's finally seen in the outpatient clinic. So we know specialist outpatient clinics in Victoria have significant gaps, and there's a significant reform happening at the moment. But what we're currently faced with in our existing system is long waiting times. We know that 1 in 4 Victorians who live in metropolitan Melbourne are waiting longer than is acceptable to get a specialist review. If you live in regional or rural Victoria, that increases to almost 1 in 3. So there's a geographic inequity as well. We know that specialists are really poor at using virtual care, and we know that if you're delayed in getting that care, you've got poor healthcare optimisation that can lead to poorer healthcare outcomes, as was the case with Jordan. We also know it's a very fragmented system. So you write a referral letter. By the time the patient's seen, that may or may not be in date. It may or may not have the pertinent question. You then get a letter in return, which may or may not answer the question that you had. There's no ability to share information. There's no ability to ask clarifying questions. And because the specialist doesn't have a relationship with the primary care physician, they bring the patient back into specialist outpatients to see and feel the need to hold on to that patient until things have completely resolved, knowing that a discharge means going back on that waiting list for another 18 months. And that becomes a perpetual cycle. Now imagine if Jordan's GP had known about virtual specialist consults. So in this version of the story, she's able to tap into an appointment in 2 weeks' time that suits both her and Jordan. They speak with the respiratory consultant. Together they land on a new medication. The respiratory physician has used it a couple of times. It's relatively new, but she's had some good results. And this works miracles for Jordan. His symptoms resolve. He's able to stay in basketball. He stays fit and healthy. He's able to participate fully in work, and he's got no financial difficulties. A completely different outcome for Jordan. And that's essentially what we're trying to achieve through virtual specialist consults. We're trying to overcome that fragmentation, bring everyone together in the room, bring the key decision makers. So the patient brings their knowledge of their values, what they're prepared to do, what's important to them. The GP brings the background, history and knowledge, what they've tried before, what works, what hasn't worked. And the specialist is really there bringing their nuanced area of expertise to bring to the table. Because everyone's working together, we're able to keep that appointment time really brief to 20 minutes, and that allows us to have really timely access to our clinic. Because people are able to have a direct dialogue, we can ensure that the GP asks any clarifying questions, fully understands the plan. That allows some capacity building, and it allows the GP to feel confident the next time they see a similar patient and perhaps managing that patient in a similar way. The management stays with the GP, and that's really critical because that avoids long appointments, that avoids repeat review appointments, and it also allows us to keep our appointments really timely, so avoids those delays in care. And by virtue of being virtual, we can obviously overcome the geographical barriers, so improving equity of access as well. So it's about reframing the role. Instead of handing over the care to the hospital system, the patient then getting stuck in the hospital system, the specialist moves away from being a manager and comes back to the role of just providing their advice on their expert nuanced area. The care stays with the GP, the continuity of care is preserved, and we're able to shrink the waiting list, which is a really important outcome. Many of you will have used virtual specialist consults, but if you haven't, then booking is easy. You go to our website, virtual specialist or vsconsults.org.au. We've bundled our specialties in adults and pediatrics for ease of navigation. We've got a large list of both pediatric and adult specialties that you can engage with. This list only goes to O, but we go all the way down to wound at W. Once you've found the specialty, you'll be able to see the different types of consultation that you can engage with per specialty, and I'll talk you through those now. So every specialty we offers a case conference or a co-consult, and that's really the backbone of our model. You pick the time that works for you, and then there'll be some booking details. You'll then receive an email with the Health Direct link at the time of the appointment, which you can forward on to your patient if you wish for them to join you virtually, or you can have your patient join you in your rooms. To get the most out of your co-consultation, it's really critical that the GP or the primary healthcare provider, we have a lot of psychologists and nurses that use our service as well, but the person who is the referrer and knows the patient presents the patient. We expect the dialogue to be primarily between the referring clinician and the specialist. The patient is there to correct any misinformation, to respond to any clarifying questions the specialist might have that the GP or primary care clinician hasn't yet gathered, and there to contribute to the shared decision making. But predominantly the model is centered around a dialogue between the referring clinician and the specialist. And without that, if we go back to the specialist having to take the history from scratch, we can't keep to that 20-minute appointment time. So that's a really important premise of the service that we offer. The specialist is then able to give their advice based on the information they've gathered, and it sits with the GP to decide whether they're going to take on that advice and follow through with the management plan. The GP then decides, or the primary care clinician decides, when they would like to tap into that service again. So there are no planned reviews. It goes back to the community with the opportunity to tap back into a virtual specialist consult appointment when and if the need arises in the future. If instead of a co-consult, you would prefer a case conference that's on the booking sheet, you can choose whether you bring a member of your clinic staff into that appointment or whether you want us to find a third clinician. Now, we provide this as an option for those cases where you might want to have a discussion without the patient there. And there may be situations where the conversation will flow a bit more easily if you can discuss things that might not be so easy to discuss transparently with the patient present. We're quite transparent that we bring the third healthcare provider in to meet Medicare billing and billing purposes, but we try and add value with that third healthcare professional. If you've got a clinic nurse that would add value by being part of that consultation, that's great. Otherwise, we will bring in a healthcare provider from our service that makes sense. So for thrombosis, for example, we'll bring in a pharmacist. In our diabetic clinic, we'll bring in a podiatrist. So essentially the case conference is an identical model, the patient doesn't attend, it allows you to maybe speak a little bit more openly about some things you might feel uncomfortable saying in front of the patient. We bring in a third healthcare provider, but for all intents and purposes, it's the same setup. We expect the dialogue to be between the referring clinician and the specialist, and the management stays with the clinician in the community. Across our co-consults and case conferences, this has been the impact that we've measured. For those of you who have used our service, you will know that you get a REDCap survey at the end, and we get a fairly good response rate from that. What we've learned is that prior to engaging with virtual specialist consults, 60% had either booked or were planning to book an outpatient clinic. Following a single 20-minute co-consultation, that drops to 12.5%. Furthermore, the 12.5% that do need ongoing care in a definitive specialist outpatient clinic, we're able to address some of that really low-hanging fruit, make sure the early investigations are done, make sure the early treatment trials are done. So by the time they finally get that appointment, they're that much further on their patient journey, and they can get lots of value from that first visit with the in-person provider. And 99.8% of clinicians who use our service agree or strongly agree that it makes a meaningful difference to their patients' management. Here's a beautiful quote that we include on our website, courtesy of Catherine, who's happy for us to share, but she's given the feedback that for her as a regional GP, she's used the service lots of times, and where she finds it most valuable is those cases where it's a bit grey. She thinks she's doing the right thing, but she's not sure. Again, if you've filled our REDCap survey, you'll know we collect that information. And the two most common reasons that GPs are using our service is either to get a second opinion or just for reassurance that they're actually on the right track. They've reached the extent of their experience to date, and they just want that confidence that what they're doing is the right thing to be doing. And I like the bottom line, which you know, Catherine says she learns a lot and she really enjoys it. And of course, GPs can get CPD through attending our co-consultations and case conferences as well. In terms of outcomes that matter to patients, we did a 3-month study over winter last year, and we compared our top 6 specialties in virtual specialist consults to those same specialties on a waiting list at Northern Health. And what we discovered was that there was a cost savings in travel alone of $135 per patient per clinic. Now that's the travel alone, so that doesn't take into account the time off work that you need to take to come in and out, the time to park, to wait to be seen, to drive back home. The waiting time was reduced from almost 3 months to 20 days. 100% of GPs who used our service in that time would recommend virtual specialist consults, and 87% did not feel they needed a referral to outpatient clinics after using the service. We also offer the e-consult model in a selection of specialties. You would have seen that in the cardiology. And this is really it's like an email. You write a brief description of your patient. We ask for it to be a generic question. We don't want any patient identifying variables. And then the specialist responds based on the information they have access to. When you get that response from the specialist, which we promise to deliver in 3 business days, then it's up to you to decide whether that advice really resonates with you, knowing that you've got a much broader picture and context of the patient that the specialist does not have access to. I've shared a couple of examples here. Here's one to our endocrinologist who was asking about raised prolactin and whether this medication was likely to be the cause, and says a really targeted question at the end: is this the likely cause? She's asymptomatic, she doesn't want to stop it. What do I do? And the specialist, Henry Wong, who's our endocrinologist, writes a very succinct response. Yep, you're right, that's probably the cause. And then he gives 3 different options for the GP to consider. You can either substitute the medication, you can keep it going because she's asymptomatic, or you could stop it, see if things improve, then you've got your diagnosis and restart it at a low dose. So it leaves it to the general GP to decide what to do. Here's one to our haematologist. Again, a very brief generic background with a specific question. I've got a patient, their bloods look like this. Do I need to refer, or can I just continue to monitor and get some confirmation? No, sounds like you've done an adequate workup based on the information you've provided me. Keep monitoring, and here's some parameters at which point you might consider referral. So a really quick, easy way for you to get some advice, some reassurance that what you're doing is actually the most up-to-date way to manage your patient. We've had 193 e-consults to date. Our most common specialties are endocrinology and haematology. They lend themselves really well to that sort of generic, non-specific advice. We ask everyone who completes an e-consult, what would they have done if they couldn't have accessed the service? Over half would have been referring to an outpatient clinic. Some would have picked up the phone and dialed a friend or dialed the lab, and some say they would have continued to manage in primary care, but without that reassurance that they are in fact doing the right thing, so with a level of uncertainty. I'll touch very briefly on direct referrals. The reason for mentioning this is if you do work in rural or regional Victoria, you may see a patient that has been seen by one of our VSC consultants who's been referred by virtual emergency department. When we work in VED, we see a patient who's in rural regional Victoria, we deal with the acute issue. Often there's some underlying medical issues that have not been addressed. And in that case, we refer into VSC for a one-off appointment. The idea of this appointment is not to hold on to that patient for a very long time, but it's really a one-off appointment, tease out what's going on, address any low-hanging fruit. If they do need to be referred into definitive care, to make that referral, but to optimise their healthcare while they're waiting. I also wanted to mention that we do have some direct referral pathways for GPs, so you can refer directly into these services. These are either because they're GP specialist service that not every GP feels comfortable managing. In particular, we've got a menopause clinic run by some female doctors who are experts in managing menopause. They also can do some co-consultations if you've got particularly complex patients. We run a medical abortion clinic. Services where specialist care is really timely, so palliative care or advanced care planning can be directly referred into, thrombosis clinic can be directly referred into, and we have an ophthalmologist, which our optometrist colleagues also refer and use quite heavily. And then we have some education nurse-led clinics, so children with asthma that need the asthma education reiterated can come and meet our lovely clinical nurse consultant or nurse practitioner, and we run a paediatric continence clinic as well to support patients with bedwetting. So in summary, why is virtual specialist consult a good option? It really provides you with an option to get timely specialist care for your or advice for your patient. It allows you to keep the patient in the community. So it provides the support to manage complex patients better in the community. It's providing the specialist care where you want it and when you want it, rather than when it's available. It overcomes that fragmentation in care. It brings the key parties together in a room to have a dialogue. It overcomes barriers, traditional barriers to outpatient care, particularly geographic barriers. It's a really efficient use of our specialist workforce. Keeping those appointments brief, putting the care back with primary care enables us to see a lot more patients in a really short period of time, meaning that we can provide really timely advice, and it's scalable. So these are the specialties we have on offer. We're growing every day. This list will be out of date in a couple of weeks' time. If there are specialties here that you'd really like to see that we don't have on offer, please let us know. There's a QR code to our website, and I might leave it on that with the QR code and open for questions.
Thank you, everyone. Please feel free to, I think, either put things in the chat, or you can unmute and ask away. If a lot of people are kind of talking once, we'll go to the hands up system, but we tend to just see one person at a time. So if you do have any questions, please feel free to go ahead. Asalan, we'll go to you first.
I just have a quick question, just regards to, I guess, evaluating. Sorry, I know it's a little bit out of the topic, but how do we evaluate chest pain in a virtual setting? Is there some sort of score that you guys recommend or use to stratify, like, intermediate patients where you're not really sure? Is there any score to stratify these types of patients that you guys recommend for virtual settings?
So I'll take that one. So at the moment, there's two settings where we're assessing it. One is both with Ambulance Victoria and in urgent care settings. So when we're doing it, at the moment we're just using traditional, I guess, risk stratification based on the fact that in the urgent care clinics we have access to all the information, a experienced nurse, and often an ECG, and most of the urgent care clinics have already done a troponin for us. In terms of what's coming, though, is we're about to do a research project with Ambulance Victoria where they will be introducing a new assessment tool into their workflows, which is an international assessment tools. If you email me, I can send you some details about it. They're going to be risk stratifying their patients into mild, moderate, and high risk. And what's quite interesting about this particular research project is they're going to be using point of care troponin devices in the patient's homes for those sort of low to medium risk. So I don't recall the name of the tool that they're going to be utilising. It is an internationally validated tool. If you would like to know more about it, just email me and I'm happy to pass on the details of that risk stratification. I believe it should be uploaded into Ambulance Victoria's CPG pretty soon as well. So you'll be able to actually see what they'll be using to risk stratify. But currently we're just doing clinical practice in the sense of how we'd normally manage any chest pain that came into an emergency department and risk stratify them. So there's no sort of special spicy virtual tool. We're just basically using what we would standardly use in an ED. Does that
Okay, thank you so much.
answer your question? But yeah, do reach out if you're interested in hearing more about the tool that they're going to be using for this research project.
Amazing. Thank you so much.
Thank you. Anyone else? Any other thoughts or questions? Sometimes if something comes to you a bit later, you can always email us. Always happy to bounce things around the team and send it back to you as well. Rochelle, I'll hand over to you. Oh, sorry, Rochelle. Might need to unmute yourself if you whenever you're ready to talk, go for it.
Okay. Hi. I just wanted to ask a question because according to the Safer Care, if a child has a bruise and the mother won't go to the ED, we can use virtual ED to start off with. How do you feel about that?
That is news to us. I think.
Yeah, it's in the
I
Safer
mean,
Care with the bruising.
So if we see a child and we have any concerns at all about non-accidental injury, we will be sending that patient straight in for an in-person review. So we would do probably very little more than you can do in the community. We would let the hospital know that that child's on their way, and then we would make sure that they arrive and hand over the care. So I'm not entirely sure why that recommendation has been made.
I think the only thing else we offer, Joe, is if we tend to be quite pedantic about making sure that child has arrived at the hospital if we have high enough suspicions, and there have been instances where we've sent police to households if they haven't shown up within a period of time. That is the only extra thing that we can do in those instances, is really try close the loop with child protection and police to ensure. But I agree, that's news to me as well.
Yeah, it's in
but yeah,
it's in a new I think came out this year. It's MCH, the bruising policy, and it's got like a pathway, and it mentions virtual ED on there.
Okay. Well, we're always happy to see small children. If there ever is suspicion of non-accidental injury, as Joe said, we're quite pedantic about it. There are certain sort of, I guess, social situations, non-accidental injury being one of them, where we have quite a lot of advocacy that we feel it's our duty to follow through. It's the same as if we have a patient contact us that's quite elderly from the community and they've registered a complaint that's quite concerning, and then they don't actually show up in the virtual wait room. If they don't answer their phone calls and we can't get hold of their next of kin, we see it as a duty of care to send somebody to their home to see that they're okay. So we don't do that for everyone, but there are some sort of nuances where we go, I think, a little bit above and beyond just to make sure that those patients are both physically and socially safe.
Yeah, thank you.
Thank you. Great question. Anyone else? I might wait, just do another kind of 10, 15 seconds. If no other questions, then we'll wrap it up. But please feel free to ask anything that's on your mind. Salem, over to you again.
Sorry about that. I just wanted to ask regarding patients that don't have Medicare cards and things like that. What's the go with virtual ED and specialist consults?
Yeah, I'll let Joe speak to specialist consults. For virtual ED, I've been quite pedantic from the beginning to make sure that patients don't need a Medicare card. I see it as a health equity issue. So you do not need a Medicare card to register for virtual ED. And we do a lot of engagement work with the refugee community as a result. We're happy to see overseas travellers. These are still patients that will come to an ED that often don't need to be in an ED. So if we can sort them out in a 20-minute virtual consult, I'm much happier to see them. They don't create a lot of burden to us, and I see it as a health equity issue. So no, we don't require it. It does create some complexity, as I'm sure you're aware, in terms of e-prescribing, because if you don't have a Medicare card, it's a bit difficult for us to e-prescribe. But we have ways of mitigating for that. And particularly with the refugee community, we work with some of the local hospitals as well to provide free access to sort of diagnostics, radiology, and subsidized medications where needed.
And do the patients still get billed at the end of the day, or is it like more of a, okay?
Not
Okay.
if they came through virtual ED, no, not at all. Joe, do you want to, I think it might be a bit different for VSC, so I'm just going to hand over to Joe.
It is trickier in VSC. We certainly do it. So we, particularly patients who need medical termination of pregnancy, for example, we will see them without a Medicare. We can't bill. So we're essentially having to offset our, we're having to cover the costs of that patient care ourselves. But as Lauren says, it's a patient equity issue. And so we do it, but it's certainly not, we would much prefer the vast majority of patients using our service are Medicare, because that is how we fund, that's how we remain sustainable, and that's how we can keep the service open to everyone. But it is possible.
Amazing. Thank you so much.
Thank you. And I might maybe do one last question. Hand over to Joy. Thank you, Joy.
Good evening. Sorry, I just checked that it's a virtual specialist clinic. Is it just for Victoria, or we can do it as well in Queensland?
Sorry, it's just Victorian.
Victoria. Okay, that's good. Thank you.
If you're in southern Queensland, Mater or the Mater Hospital does e-consults, I think, but I'm not sure what else is up there.
Queensland was actually a trailblazers for e-consults, Joy, so...
Yeah. Wonderful. Thank you, everyone. It's been wonderful to hear the story, the evolution, and the options available. If anything does come to mind around things we can clarify, areas that we're doing really well, that we can continue to improve on, areas where there could be room for improvement, please feel free to contact either of the services, or you can go through the Northern if you can't quite decide which one is the right one. It usually filters through. And I think, Lavella, I might just quickly hand over to Lavella for one last question, and then we'll wrap it up there. Over to you, Lavella. Lavella, can you hear me? You can unmute if you want to ask a question.
So just with regards to billing, for example, for the Victorian Specialist Consult, do we just bill according to time, or there's a special billing for that?
Yeah, very good. I might quickly answer that one. So on the website, the VS Consults website, there's a more information tab, which has information around like the kind of Medicare rebate codes. Currently, for a co-consult, it would be just time-based, though there's a little bit in the works around a new item number that provides a higher rebate to the patient. And obviously, you can do a gap on top, a private gap on top of that if that's what your practice does. And for a case conference, it's the 735 or I might get it wrong, but I think it's the 739 for whatever time fraction is spent doing that case conference as well. But as the GP who's organising it, you'd be claiming the organising item number for the case conference.
Thank you.
And for e-consults, it would just be within your normal workflow. So again, if it pushes you into into the 20 to 40 window, then that would just be what it would be. Thanks, everyone. And again, thank you all for your time, and we hope to see you at our next education session. So we'll send some more information out in the coming weeks. Thank you.
Thanks everyone for coming.